much higher if the vein was healthy up front?
I haven't done it until now, but I've written it down here to think about when I get home. But
There actually is a paper addressing this, and I've forgotten who the author is, but it was, I think if you had three occasions of SVT, that there's a higher likelihood of having a carcinoma. And for those that are spontaneous, it's either thrombophilia or cancer.
Okay. I'm not sure I recognize quite as strongly as you do the two different types. I think there's quite a big overlap. I don't think it's quite so separate as it sounds.
Yes, I'd agree with Jonathan, but rather than just having a panel discussion, Maher, do you?
Maher Hamish from Manchester. Just a question on the same topic, actually. Is there any certification for protocol how far from the saphenofemoral junction, 5 centimeter, 6 centimeter, or no, for this connection? And from this large debate, is it time to do a randomized trial to decide between mechanical and pharmacological treatment for this condition? Thank you.
So the question is, Tony, does it have to be going all the way to the junction before you intervene, or if you're 10 centimeters away from the junction, is it safe to leave?
Well, I think it's what do you want to offer your patient, and what would you want done if it was your leg? I mean, it boils down to about that. And you know that it's very easy to get rid of the vein. It's very easy to get rid of the thrombus. With a little inguinal incision, you can do all of that in one sitting, and with a week of prophylaxis, the patient is cured without a risk of a serious venous thromboembolic event. Now, if you keep the patient on anticoagulation, the patient will have a high risk of recurrence. The patient will need additional, in all likelihood, will need additional interventions if you're going to intervene later on to ablate the saphenous vein. And not all patients will be able to be recanalized, or at least you're not going to be able to pass the catheter through all patients. Some yes, some no. So you're taking a simple procedure, making it difficult. You're taking a potentially curable situation and putting the patient through a longer
Tony, can I just not come back to that, because I may have got it wrong, but did you not present the data suggesting that the group that actually had surgery had a higher VTE complication rate at the time of intervention?
Yes. And
sorry, may I intervene, because I don't understand the discussion. He lost. Why are we talking to him? Why are we not talking to Lowell?
Lowell's enjoying his lunch.
I appreciate that, because I'm listening to it and I'm going, shaking my head.
Actually, you can leave it to Case to come up with things like what was the question?
I thought you'd paid Case very well not to answer my question. My question is that in your surgical group that you intervened on, there was an increased incidence of VTE. So in a way actually defeating, in my view, the purpose of doing the intervention.
No, actually it's a good point, and I'm glad you brought that up. When you look at the surgical series, most surgically treated patients are never treated with anticoagulation, even in prophylaxis after the procedure. And you've seen the association of an aggressive thrombophilia with superficial vein thrombosis. So all I'm saying is that why not protect these patients who are at high risk of a venous thromboembolic event after you do the definitive procedure for a period of time? And if you then want to ask the question, well, should we be getting a thrombophilic evaluation in everyone? I think that's a reasonable question. I don't have the answer for that.
Can I just use chairman's privilege? Because I'm a bit like Jonathan, I'm a little bit confused. But can I just go through the panel and ask, if you've got a patient who presents with a superficial vein thrombosis, are we all now saying that all these patients should have low molecular weight heparin, or are we recommending non-steroidal anti-inflammatories? Because actually most of these get treated in the community. So what should we actually be telling our primary care physicians to do with the majority of patients who present with a superficial vein thrombosis? So Iris, what would you advise?
I mean, although not right now written up in the guidelines, I mean, having heard the presentation of the Callisto data, that low molecular weight heparins given for at least 45 days can get a relative risk reduction of 85% for pulmonary embolism. What's important from the medical point of view,